us, please admit them. I'll start sharing my screen. Can you see the presentation now?
Yes.
Okay, brilliant. So let's start. Okay. Okay, so retinoblastoma is the most common primary intraocular malignancy in children. Those who are working with children knows that the most common malignancy to find in the eyes of those children is retinoblastoma. It's a tumor coming from the what we call the primitive neuroectodermal intraocular neuroectodermal cells. So in the retina, there are neuroectodermal cells. When those cells turn malignant, they give this retinoblastoma. And it's the second most common malignant intraocular tumor after malignant melanoma. The importance to detect and treat this condition that it can lead to death due to the complications of the malignancy. We need to know that the incidence varies in between countries, and the retinoblastoma represents slightly more than 5% of the cancers in less than 5 years old. Mostly, it presents in young age, before 5 years of age. The mean age of diagnosis is 18 months, and the most common presentation is with leukocoria, like this. So you find a whitish red reflex, which is either seen with the naked eye or accidentally discovered while the patient is taking a photo. You'll find the red reflex is normal in one eye and abnormal whitish red reflex in the other eye. Or it can present with strabismus. So please remember that in every single patient with strabismus, the first thing to do is to do cycloplegic refraction and fundus examination, because you may find retinal problems in those children presenting with strabismus. This is a very, very important message that you need to know. So one thing that you need to understand is the difference between heritable and non-heritable retinoblastoma, or unilateral and bilateral retinoblastoma. If you find a patient with bilateral retinoblastoma, those patients by definition have what we call a germ-line mutation. So could you please admit our colleague? So bilateral retinoblastoma means that this patient has what we call a germ-line mutation. And in a few seconds, we will understand what's the meaning of a germ-line mutation. While in patients with unilateral retinoblastoma, most of them has what we call a somatic mutation and not a germ-line mutation. So the mutation is present only in the tumor cells and not in the all cells of the body. And only 15% of them may have a germ-line mutation. In other words, germ-line mutation mostly present as bilateral retinoblastoma, but can present as unilateral retinoblastoma in 15% of the cases, while somatic mutations will essentially present as unilateral retinoblastoma. The incidence is equal in male and females, and there is no race predilection for retinoblastoma. So it's almost equal in all races. When we if you want to understand the genetic basis of the retinoblastoma, we need to understand what's called the two-hit theory, or the two-hit mechanism. So in the beginning, we thought that there is what we call the oncogenesis, or a gene that promotes the transformation of a normal cell to a malignant cell. We thought that this gene will become active and it will initiate the retinoblastoma cell and initiate the tumor. But later on, our understanding got better. So we realized that rather than having what we call an oncogene or a gene that promotes the tumor formation, we have another thing which is called the suppression of a tumor suppressor gene or a mutation in the tumor suppressor gene. So we have a gene that suppresses the malignant transformation. We have 2 copies of this gene on the 2 loci of the chromosome. And in order to have a malignant transformation, we need to have inactivation of both loci of the tumor suppressor gene. So we need to have 2 hits, one of them to the first locus of the chromosome and the second one to the second locus of the chromosome. It's exactly like when we talk about, you know, the autosomal recessive and the autosomal dominant genetics, when we say that for the autosomal dominant, for the autosomal recessive, both genes present, inherited from the father and the mother, should be present in order for the character to be inherited or to be expressed. It's exactly the same. We have 2 tumor suppressor genes on the 2 loci of the chromosome, and we need to have suppression of both of those 2 loci. The first hit can be either a somatic or a germline. So it can be either inherited in the germline and present in all cells of the body, or it can be a somatic mutation, so affecting only the tumor cells. And this represents the first hit. Then the patient will get a second hit, and he or she will develop retinoblastoma. Is this slide clear for you or not? If you want me to repeat it in another way, just let me know, please. Did you get the idea of the tumor suppressor gene inactivation? Anyone having problems with this? Okay.
Okay, doctor.
Okay, so let's move on. So inheritable retinoblastoma, which is essentially, which presents as bilateral retinoblastoma in all cases, and 15% of the unilateral retinoblastoma, we have inheritance of a mutated gene from the father or the mother. So the germline cells will have 1 mutation. So we have a 1 hit inherited from the mother and or the father. And then the patient will develop a second hit, and he or she will develop retinoblastoma. So it's easy to get the second hit because basically, if the first hit is not inherited, it's a bit more difficult to get a couple of hits in the cell. But if you have already one locus gone at birth, so it's easy to get the second hit and to develop the retinoblastoma. Usually, those patients will develop in a relatively younger age than patients with somatic mutations. Some of them may have a new mutation in the germline and not essentially inherited from a parent. We understood that the retinoblastoma 1 gene, which is a tumor suppressor gene rather than an oncogene, is present on chromosome number 13. So it's present in this location of the genetics. Okay, and this is why there is an association between a syndrome called the 13q syndrome and the retinoblastoma. Those patients will have mutations in chromosome 13 and they are more prone to develop retinoblastoma. Okay, so usually the heritable retinoblastoma, which represent 40% of the cases, as we mentioned here, 40% of the cases will have heritable retinoblastoma. It usually presents as bilateral multifocal tumor. So it's not uncommon to find the tumor in both eyes and to have multiple foci of the tumor. So 1 here, 1 there, 1 here, 1 there. And when you treat this one, later on in the follow-up, you may find another one because all of the cells, they have already had the first hit before birth. and it's not difficult to get a second hit in multiple cells in different locations of the retina. Okay, there is a higher risk of secondary tumors and what we call the trilateral retinoblastoma. Those patients will usually have a pineal body tumor, and there is a 40% chance to transfer the gene to the offspring. Why it's 40% chance? It's an autosomal dominant inheritance, so it's 50% chance, but it's what we call an incomplete penetrance. Incomplete penetrance, that means that the autosomal dominant gene will not be expressed in 100% of the cases. It will present itself only in 90% of the cases. And this will decrease the chance of transferring the retinoblastoma to the offspring from 50% to 40%. So if a patient is coming with a bilateral retinoblastoma and the parents will ask you, can we get another patient? Another baby? What is the incidence of developing retinoblastoma in the second child? If the parents are affected, as we mentioned, the chance is 40% because it's inherited from the father or the mother. If the parents are healthy, then usually this infant developed a mutation in the germline, but this mutation is not inherited from the father or the mother. So the risk of having a retinoblastoma in another offspring is extremely low, 2%. Is it clear for you, or you want me to repeat? It's not easy to understand this part, but I want to make it easier for you. So if you don't understand anything, just let me know. Any problems?
Doctor, I wish to understand when you talked about the inheritance.
The inheritance.
Yes, you say that the first hit is inherited from the patient, from the parent.
Exactly.
And the second hit is easily acquired. How is it acquired?
It's acquired, we all have some sort of ongoing cell damage, whether due to the ultraviolet rays, due to carcinogens in the food, due to whatever. So it's not uncommon to have some damage to the DNA, but usually the DNA corrects itself. But if the first gene is already damaged, so the DNA will not easily correct itself, and the tumor suppressor gene will not do its job by suppressing the tumors, and the malignant transformation will go on. Did this answer your question?
Okay, yes. So what form of inheritance, if you asked, what is the kind of inheritance it is?
So it's usually, if the retinoblastoma gene is inherited as autosomal dominant inheritance. If you remember the Mendelian inheritance, we have autosomal dominance, autosomal recessive, X-linked dominant, X-linked recessive, etc., etc. This one is autosomal dominant. So the gene can, the chromosomes of both the father and the mother will divide into halves, and then the baby will get half of the chromosomes from the father and half of the chromosomes from the mother. If by chance the gene is transferred from the parent to the offspring, there is a 50% chance of this transfer, because half of the chromosomes, each chromosome is split into halves. The chance of having the gene is 50%. But because the penetrance here is 90% and not 10%, so the final chance of developing the retinoblastoma in the offspring drops down from 50% to 40%. Okay?
Okay, Doctor.
We should realize something very important. The germline mutation doesn't necessarily mean that it's inherited from a parent. The baby during the embryogenesis can develop a mutation, a new mutation. It's not inherited, but it's present in the germline, so it will go to all the cells of the body. And this is why here we say that if the parents are healthy, the risk of having retinoblastoma in another offspring is low. This indicates that the retinoblastoma gene, rather than being inherited from a parent, it developed early in the embryogenesis in one of the germ cell lines that divides to give the cells of the body. So all of the cells are having this abnormal gene but it's not inherited from the parent. Okay?
Okay.
So moving to the other form, which is the non-heritable or non-hereditary or somatic retinoblastoma. Usually, those are unilateral and solitary, so they are not multifocal. Usually, they are not transmissible. It's a new mutation that developed in one of the somatic cells rather than the germ cells. There is no risk of second non-ocular cancer like the pineal body or what we call the trilateral retinoblastoma. The risk in each sibling is about 1%, so the risk is extremely low because it's not inherited and it's not in the germ line. Most of the patients with unilateral retinoblastoma will have non-hereditary form of the retinoblastoma. See, it's not inherited from the parents. Okay, only 10 to 15% may have heritable retinoblastoma. So, we have different classification systems of the retinoblastoma. It can, if it's, it extended outside the eye, so we will need to define whether this extension is orbital, so it's a local invasion, or it's a distant metastasis. But most of the tumors are discovered while they are still intraocular. And we have two classifications for that. The first one is the Rees-Ellsworth classification. In the past, we used to treat retinoblastoma with external beam irradiation. We no longer do this at the moment. We now use chemotherapy as the primary form of treating this condition. So in the past, the classification focused on the treatment according to the treatment modality present at that time, which is the external beam irradiation. This is why in the past, Rees-Ellsworth classification was more popular. But nowadays, we use the international classification of retinoblastoma because we use the chemotherapy. So the Rees-Ellsworth classification was developed in the 1950s, and at that time, we used the irradiation, and it was predicting the prognosis of globe salvage. So can we preserve the globe, or no, we will not be able to preserve the globe, and we need to go for enucleation. So it, has several grades extending from the very favorable to the very unfavorable, and it depended on whether the tumor is unifocal or multifocal, what is the size of the tumor, what is the location of the tumor, is it behind the equator or in front of the equator. And in general, patients with small sized tumor, single tumor rather than multifocal tumors, post-equatorial tumors were easier to treat and were favorable. But on the other hand, patients with multiple tumors, large-sized tumors, extending pre-equatorially to the ora serrata or vitreous seeding or massive tumor involving more than half of the retina, were having unfavorable outcome. We rarely use Rees-Ellsworth classification nowadays, but it's something in the history that you need to know about. What we actually use at the moment is the international classification of retinoblastoma. Nowadays, we use the chemotherapy because the irradiation was not, firstly, it was not very effective, and then it had higher risk of secondary tumors like the pineal body tumor, for example. The international classification of retinoblastoma focused, on the fact that the retinoblastoma, early detection of retinoblastoma, if you do early detection, retinoblastoma may be completely curable. So we here not talk only about the salvaging of the eye. We here are talking about curing the condition and preserving the vision, and not only the eye. Okay, and because this is there is improvement in the chemotherapy, so the need for enucleation or external beam irradiation has become less and less nowadays. So in general, small tumors, when they are confined to the retina, they are either A or B. A has a very, very favorable outcome. E has the worst outcome. So A and B, both of them are still, the tumor is still confined to the retina. While C and D, they are becoming more extensive. They have seedings to the subretinal, subretinal space. So those patients will develop what we call exudative retinal attachment with, invasion of the subretinal space by the tumor cells, or they will break through the nettera and give vitreous seeds. Or when this is local, this is C. When it's diffuse, it's D. And in both of them, it's not just confined to the retina. No, there is subretinal fluid invaded with the tumor or vitreous seeds. E means massive involvement of the globe. The globe is non-salvageable, and probably enucleation will be the treatment for stage E. So if we look, stage E means small tumor located only in the retina, and usually it's not very close to the fovea or the optic disc. If it's larger in size or close to the fovea or the optic disc, but still confined to the retina, we move to stage B, which is slightly worse than stage E. Stage C, it has started to grow extraretinally, so it either invades the subretinal space or invades the vitreous and gives those vitreous seeds. Stage D, it's like stage C, but it's more extensive. Stage E means there is extensive retinoblastoma progressing to neovascular glaucoma, diffuse infiltrating retinoblastoma causing media opacity, or atrophia orthitis bulbi, or aseptic orbital cellulitis. The tumor started to invade the orbit. Okay. So any problems with the classification? The importance of the classification, this is the common language between the ophthalmologist and the oncologist. So as we will see later on, the treatment needs combined efforts of both of them, and they need to speak a common language. Let's move to the pathology. The main histopathologic feature of the retinoblastoma is the retinoblastoma cells. If you remember, in the pathology, there were some features of the malignancy, including what we call increased nucleocytoplasmic ratio, including hyperchromasia. So you find that if this is a normal cell, you find that those malignant cells having dense staining of the nuclei, what we call the it's called increased nucleocytoplasmic ratio. This hyperchromasia, it's called the hyperchromasia, and increased mitotic figure. So you find that this cell is going as if it's going into mitosis. Those are features of malignancy. When you find them, you find that this is mostly a malignant cell. So you find that in the specimen, what we call increased mitotic activity, increased apoptosis, increased nuclear cytoplasmic ratio. Usually the retinoblastoma cell tend to grow around the blood vessels, as a cuff around the blood vessels. One of the important clinical features, as we'll see later on, of the retinoblastoma is the calcification. Why does it happen? Because when the growth of the tumor outgrow the vascular supply, the cells will start to suffer necrosis, and the necrotic cells will undergo calcification. And this explained why we find it's common to find calcification in the retinoblastoma. We have what we call the poor prognostic signs of retinoblastoma, including if there is optic nerve invasion, if there is massive choroidal invasion, if there is poor differentiations of the cells. So even the malignant cells may have variable degrees of aggression. Some tumors are very, very aggressive, so they grow very quickly. They respond very poorly to the chemotherapy. They tend to, give a rapid metastasis or rapid local spread. And some of them, they are still malignant, but they show some degree of differentiation and some degree of, less degree of malignancy and aggression. So if we find signs of good differentiation, this is usually a positive thing. Usually this comes in the report of the pathologist after enucleation of the eye, but it will give us a degree of, a bit of information about whether this tumor is very aggressive or not. So more differentiated tumors tend to grow in a pattern rather than, growing haphazardly. They have a pattern. So they can either give a rosette or what we call a floret. A rosette means a ring, it can be either a Flexner Ventersteiner rosette, this one. Those are ring of cells around an empty lumen. So we have an empty lumen here, and we have some, cells. They are still showing signs of malignancy under the microscope. So the hyperchromasia, the mitotic figures, the apoptosis, etc., etc. But there is some arrangement of those cells because they are not, very malignant. They are not very aggressive. They are not undifferentiated. There is some degree of differentiation. And when we find this differentiation, we are a bit happy that this is not a very aggressive tumor. Or we have the other form of the rosette, which is called the Homer-Wright rosette. Here, rather than having the clear lumen, we have this eosinophilic fibrillary center around which the cells are arranged. Or we can have the florets. The florets, here the retinoblastoma cells will have some degree of photoreceptor differentiation. So they have some feature of the rods and the cones. There's no, because it's not very aggressive, so it's not common to find aggressive mitosis, aggressive necrosis. And when we find these florets, sometimes it's classified as retinoma or retinocytoma. So it's not, considered a malignant retinoblastoma, but it is considered like a benign form of the tumor called the retinoma or the retinocytoma. Any problems with this slide? Okay.
It's okay.
Okay, great. So screening for retinoblastoma can be done on 3 levels, either with a neonatologist. So when a baby is born, he or she should be examined for the red reflex during, after birth, and in the subsequent visits, the doctor, the pediatrician should look with the direct ophthalmoscope to check if there is any abnormality with the red reflex. Pediatric ophthalmologists should, screen the infant if there is a positive family history of retinoblastoma and, the offspring and siblings of the affected patients. Genetic counseling for families with a retinoblastoma, either in the parents or in one of the offspring. They may need to have some tests done to determine whether it's heritable or not, and what is the risk of having, the gene in the offspring, and can we do a what we call a chromosome selection or something like this to decrease the incidence in the other offspring or not. Okay, so it's done on 3 levels. When we talk about the clinical presentation, the earlier we do the prognosis, the better. The most common presentation is leukocoria or strabismus. Again, don't forget, every patient with strabismus should have a fundus examination done as a first step. You probably may want to do other things before, prescribe glasses, do surgery. The first thing to do, just dilate the patient and have a look with an indirect ophthalmoscope in the eye to check if there is something wrong or not. Okay. In advanced cases, we may have a picture like this. So again, orbital cellulitis in children, especially if there are no signs of, active acute inflammation, if there's no redness and hotness and loss of appetite and this kind of thing, always think that this may be retinoblastoma. You should take that into consideration. Okay. So we have, in the late presentation, we have what we call the diffuse infiltrating retinoblastoma. If left untreated and, the tumor is aggressive, so the patient may have pain and intraocular inflammation, giving a picture like spontaneous endophthalmitis, or may present with vitreous opacity, a picture like a vitreous hemorrhage, or may present as preseptal or orbital cellulitis. If it will spread locally to the orbit, it will, give an orbital invasion. This can happen via the choroid, sclera, or the optic nerve, or it may give distant metastasis to bone, liver, or the CNS. Okay, so we should work in collaboration with an oncologist to look for these features of the late presentation. So when you are examining a patient with retinoblastoma, you need to check the red reflex, check the vision, check the pupillary responses, check if there is proptosis because it may indicate some local invasion of the orbit. Check the anterior segment, see if there is any tumor invasion of the anterior segment or not, if there are any signs of pseudohypopion that may happen in diffuse infiltrating retinoblastoma, if there are signs of secondary glaucoma like ophthalmos or something like this, then you do need to dilate the patient and check for retinal masses either with an indirect ophthalmoscope or photography by a red cam or a fundus, a fundus camera, and later on we may need to do an ultrasound. As we will see later on, the ultrasound is helpful to confirm the diagnosis. If you find calcification, then this is retinoblastoma, because as we will see later on, there is a differential other causes of leukocoria, like retinopathy of prematurity, like toxocariasis, etc. If you will find, like Coats disease, if you'll find calcification, this is retinoblastoma. And in addition, it gives you a good idea about the documentation of the size of the mass. If there is a mass, you can get the dimensions of this mass by the ultrasound. Okay. You may want to do examination under anesthesia to confirm the diagnosis and to complete the staging and the laterality of the tumor. In the fundus examination, when you examine the fundus clinically, you need to classify the tumor as endophytic, exophytic, or diffuse infiltrating. Endophytic tumor means that it tends to grow towards the vitreous cavity. It tends to not to give a retinal detachment, but rather it grows towards the vitreous cavity, and usually it may break through and give vitreous seeds. Okay. On the contrary, the exophytic tends to give retinal detachment with accumulation of subretinal fluid, and this subretinal space will be invaded by the tumor cell. So it tends to grow underneath the retina and not towards the choroid. Okay. And it's very common to find exudative retinal detachment in this form of the tumor. Okay. And subretinal seeds rather than vitreous seeds. Large tumors may have a combination of both of them, so you find a part of it endophytic and a part exophytic. Diffuse infiltrating, this is luckily the least frequent because it's the most aggressive and the most challenging to diagnose, because it mimics an endophthalmitis. So you may think that this patient is having an endogenous endophthalmitis and start to treat him or she or her like that, and later on you find out that those are tumor cells rather than infection. Usually there is diffuse thickening of the retina, pseudohypopion, chemosis, vitritis, but without the classic calcification, and this makes the diagnosis even more and more difficult. The B-scan ultrasound, as we mentioned, it is helpful to detect the calcification, so it appears as hyper-echogenic structure, and it is useful to detect if there is associated exudative retinal detachment or not, and it's useful to document the thickness of the tumor, the size and the dimensions of the tumor. This is the importance of the B-scan ultrasound. CT, we don't do CT frequently. It's useful. CT is, depends on using X-ray or some sort of irradiation. So it's useful to show the calcification, shows the calcification, and it defines the size of the tumor, but we don't order CT frequently in patients with suspected retinoblastoma, because the irradiation may provoke secondary tumor formation. So we don't use CT as a routine thing in patients with retinoblastoma. Rather, we use MRI because it's useful to show if there is optic nerve involvement or not. It's useful as it shows if there is neuroectodermal tumor, the pineal body tumor, or what we call the trilateral retinoblastoma or not. And in addition, the features of retinoblastoma can be easily detected on the MRI, so it can confirm the diagnosis if you are not sure if it's retinoblastoma or not. By the way, if you look at this one and that one, sorry, what is the difference between the CT or the MRI? This is a CT or an MRI. What do you think? Is it a CT or an MRI? Without looking, of course, to the title of the slide. How can you know that this is a CT? Does anyone
because
know?
the bone is white.
Exactly. Look at the bone. Here the bone is white, but here the bone is invisible. So this is the skin. The bone is invisible here, and you see the soft tissues rather than the skin, rather than the bones. Okay. Other tests that may be done by the oncologist: bone marrow examination, lumbar puncture, to see if there is metastasis or not. So the differential diagnosis will include causes of leukocoria. On top of them, cataract, Coats disease, persistent fetal vasculature, or what we call persistent hyperplastic primary vitreous, as we'll see later on, retinopathy of prematurity, toxocariasis, etc., etc. So one of the most important things that we need to differentiate is the Coats disease. Coats disease is usually characterized by telangiectatic blood vessels with retinal, subretinal fluid and retina and hard exudation. Usually those telangiectatic blood vessels are seen. So when you examine the patient, you find that there are some abnormal blood vessels. Usually there is hard exudate and massive subretinal exudation. Usually it causes xanthocoria rather than leukocoria. So the mass looks yellowish rather than whitish or grayish whitish in color. Usually it's in boys and in an older age, 6 to 8 years, and not less than 5 years, like retinoblastoma. And usually the fluorescein angiography is very useful to show those telangiectatic blood vessels, or what we call light bulb aneurysm like blood vessels. Okay. So the things against, it will make you think that it's retinoblastoma rather than Coats disease. If it's bilateral, then it's mostly retinoblastoma. If it's whitish rather than yellowish, it's mostly retinoblastoma. If there are no telangiectatic blood vessels, it's mostly retinoblastoma. If there is calcification, it's mostly retinoblastoma. If it's in a girl rather than a boy, it's mostly, but not conclusively, retinoblastoma. If it's in a younger age group, it's retinoblastoma rather than Coats disease. Why it's important to differentiate? Because in Coats disease, the treatment is by draining the subretinal fluid and doing cryotherapy on those telangiectatic vessels and giving intravitreal injection of anti-VEGF. If you do that and the patient is retinoblastoma, you are giving away to the tumor cells to spread either locally or distant, or giving distant metastasis, and this can even put the life of the child at risk. On the other hand, if a patient is presenting with a big mass and you think that maybe this is a retinoblastoma and it's better to do enucleation, sometimes we are surprised that after enucleation, the pathology report will come and say, no, it's not retinoblastoma, it was a Coats disease. But anyway, in patients with extensive Coats disease, they usually are not having useful vision, and usually they will suffer complications like secondary glaucoma, so the eye will become blind and painful, and they will need to have enucleation done anyway. But this is why this dilemma is important, whether it's Coats versus retinoblastoma. The second thing is toxocariasis. It usually, there are signs of inflammation. There is eosinophilia, so if you are in doubt, request a CBC for this patient. Usually, especially if the disease is, active and not an old disease, you'll find this eosinophilia. Hepatosplenomegaly is suggestive. Pneumonitis is suggestive, but sometimes it's not easy to differentiate them. Persistent hyperplastic primary vitreous, or what we call persistent fetal vasculature. Those patients will have this characteristic appearance. Just remember that one. You will find the ciliary processing appearing through the dilated pupil, and usually these patients having a bit of microphthalmia, so the axial length is shorter than average. Usually they have a stump growing from the optic disc and crossing the vitreous and reaching the back of the lens like that. And it may have some blood vessels. So this one is extending from the optic disc and growing through the vitreous to reach the back of the cell. And sometimes it's highly vascular like that. And it gives this appearance of leukocoria, and you are not sure if this is retinoblastoma or not. But the characteristic stalk-like appearance growing through along the vitreous is, it's characteristic. The ciliary processes, if you see them, this is very suggestive of the persistent fetal vasculature. If you do an A scan of this child and of this eye, and you find it's still it's a bit microphthalmic, so it has a short axial length. Again, this is suggestive of persistent fetal vasculature. So the tumor, how we treat the retinoblastoma nowadays? We have what we call the local therapy. The local therapy means that you ablate the tumor, whether with cryotherapy, with laser treatment, with transpapillary chemotherapy. If it's stage A, so if you remember the international classification, if a small tumor, small in size, localized, not multifocal, you can ablate that area of the tumor and salvage the vision of the patient and salvage the life of the patient. But what if the tumor is extensive, if it's stage B, for example, B or C? Here you need to do what we call a a chemotherapy first to shrink the tumor, and then you do what we call the consolidation therapy or the focal treatment. So this is the appearance of a group B tumor. After chemotherapy and consolidation, it has this appearance. This is a regressed tumor. So it has either what we call a fish flesh appearance or a cottage cheese appearance. But if you do follow-up of this patient, so later on, few months later, 2 months later, the patient started to develop a recurrence. So another recurrence started to appear here, and the patient will need to have second treatment. So nowadays we do the local treatment or the consolidation therapy or the chemotherapy or combination of them for most of the tumors. Okay. Just a second. Okay, so the general principles that the primary objective is to preserve the life of the child, and if possible, preserve the globe. So having a normal shaped globe, and if possible, preserve the vision. So try not to destruct the whole retina, just destruct the tumor and preserve the whole the remaining retina, so the patient will have a good vision. While we do the treatment, we need to understand that the treatment has side effects and complications, so we need to minimize that. We need to know that the definitive treatment of intraocular retinoblastoma remains the enucleation. So this is the radical treatment. And it's still done in patients with advanced unilateral retinoblastoma with poor visual prognosis. So the decision of enucleation will depend on two things. First of them, the extent of the tumor in the eye. So if it's stage D, for example, or E, we think that we need to do the enucleation. And the second thing is the state of the other eye. If the patient is having a bilateral retinoblastoma, or he or she has already had enucleation done in one eye, then probably you will need to weigh the risks and the benefits of having the enucleation done versus not having it done. One of them will preserve the globe, the other one may preserve the life of the patient. So it's not an easy decision. Okay. So as we said, nowadays we do the globe salvage treatment. Either for a small tumor stage A, we do consolidation treatment alone, either with cryotherapy, laser photocoagulation, like the one that we use for the diabetes, for example, hyperthermia. It's called the transpupillary thermotherapy. So in this TTT, you expose the tumor to a large beam of laser. It's of low power and long duration. So you are roasting the tumor. بالبلدي كده احنا بنحمص الtumor. Or we do what we call a plaque irradiation or a brachytherapy. We fix a radioactive plaque to the sclera so that it will irradiate locally rather than giving the external beam irradiation. We give just a small plaque of tumor which is sutured to the area of the sclera near the tumor. It will irradiate a calculated dose of irradiation that will affect the tumor only and not the nearby tissues. In patients with larger tumor, we may need to do the chemotherapy as a preparation before doing the consolidation. It can be given either intravenous, or recently we give it intraarterial, as we will see later on, or intravitreal injection, but we need to do what we call the anti-reflux technique. You don't want the tumor cells to go outside the eye, so you do the injection, as we will see later on, of the chemotherapeutic agent, and then you either do chemotherapy, cryotherapy on at the site of the injection, or you inject some of the chemotherapeutic agent to prevent the reflux of the malignant cells. Nowadays, we rarely use external beam irradiation. Only we use it if there are vitreous seeds or if there is a recurrence of the tumor, because it has several side effects. So for group A, as we mentioned, we do the focal therapies alone. Group B, we do the chemotherapy with local therapy. C and D, we do chemotherapy with multiple agents. Group E, usually we do enucleation. And, this is the thing that we do at the moment. The intraarterial treatment, it's done with a drug called the melphalan. So it's done by an interventional radiologist who will go with the catheter and go through the carotid artery to the ophthalmic artery, and then to the central retinal artery to inject the melphalan, which will go in high concentration just to the area of intention, or just to the area that needs treatment, just to the artery that supplies the tumor. So it avoids the systemic side effects of the chemotherapy. It has some side effects like the occlusive choroidopathy. So the drug or the catheter may cause occlusion of the choroidal blood vessels. Some concerns about the strokes and the optimum doses that we need to use with children. The intravitreal chemotherapy, it's done primarily for the vitreous seeds. So as we mentioned, in endophytic tumor, they are characterized by formation of vitreous seeds. If you do systemic chemotherapy, it will go through the blood, but it will not penetrate with sufficient concentration to the vitreous cavity. So the best thing to do with those vitreous seeds is to give intravitreal chemotherapy or to give external beam irradiation. So as I mentioned to you, we need to prevent the reflux of the malignant cell to the outside of the eye, so that we decrease the incidence of local and distant metastasis. Surgical treatment, either with enucleation, if there is group D or group E, especially if the other eye is normal and seeing, usually it's better to remove the eye. And then we need to know that we need to have a good stump of the optic nerve, at least 1 centimeter to 12 millimeter, to make sure that we remove the tumor completely. Do you know the difference between evisceration and enucleation, and which one we do in retinoblastoma, or why we prefer enucleation in retinoblastoma? Do you have any idea why we prefer enucleation over evisceration in retinoblastoma?
No, doctor, I'm not sure.
Okay, so in evisceration, what we do is we cut through the cornea and we start to eviscerate the intraocular structures while we preserve the sclera. But here we have tumor cells. If you will do that, you will spread the tumor cells to the nearby tissues. So here you want to remove the box while it's still closed. You don't want to open that box. You don't want to open that bomb. So you want to remove the whole globe without injuring the sclera, so that the tumor cells are still confined to the inside of the eye. So in enucleation, you just disconnect the extraocular muscles and you remove the whole eye and just cut the back of the eye, cut the optic nerve. As we mentioned, we keep a good stump of the nerve. We prefer that in order not to spread the malignant cells. Okay, we use evisceration in patient, for example, with endophthalmitis, because there's no risk that the bacteria will spread to the outside. The bacteria is localized to the eye. So you remove the inside, the contents, the intraocular contents, and you preserve the sclera to use it to put the ball, the implanted ball inside it. It will give a good support of the ball. But here you remove the sclera and you put an implant either in a fascia lata or the fascia lata that is present in the thigh. We wrap the ball that we will implant in fascia lata because we don't want to spread the tumor cells to the nearby tissues. And later on, after having a ball implanted, we put an ocular prosthesis by that will match the other eye, so it will look like the other eye. So we do enucleation first and ball implantation, and then later on we do an ocular prosthesis. You know the difference between the ball and the ocular prosthesis? What we call the shell. So the ball is implanted to replace the volume loss happened after enucleation. And then the shell is something that is put on the surface to give the appearance of that matches the other eye. Okay? Any problems with this slide? Okay. So if we have extraocular retinoblastoma, the treatment is done by the oncologist, usually by chemotherapy, surgical debulking. If it's in the orbit, we do what we call excentration. So excentration is similar to enucleation, but we remove all the orbital content. So we dissect the periosteum all around on all walls of the orbit, and we remove all the contents, the eye globe and the orbital tissues and the extraocular muscles. We do that if there is an orbital extension. If there is distant metastasis, usually we do what we call the high dose chemotherapy. So we give multiple agents and multiple cycles, etc., okay, to control the distant metastasis. Quick word about the trilateral retinoblastoma. It's another tumor that arises from the primitive neuroectodermal tumor, but it's present in the CNS rather than in the eyes. Usually it happens in germline retinoblastoma mutation, and usually it's in the pineal body. So if there is a trilateral, it's this tumor. This is not a normal tissue. This is a tumor tissue. This is why we prefer to do an MRI, because it can, detect such tumors, and it doesn't occur frequently now because we don't use external beam irradiation. We use chemotherapy, so it doesn't occur frequently. So follow-up, it should be done if eye salvaging treatment is done. In other words, if enucleation is not done, then there is always some risk of recurrence of the tumor. As I told you, we have what we call white calcific mass, or what we call the cottage cheese appearance, شكل الجبنة القريش كده, or what we call the translucent fish flesh appearance. Those are the signs. You find that the vascularity of the tumor is less, the subretinal fluid is less, and that the tumor looks atrophic in nature. Well, this is how you know that this appearance is of an atrophic tumor rather than an active tumor. So those patients will usually have examination under anesthesia every 1 to 2 months till the age of 3, and then less frequent examination. For hereditary retinoblastoma, we need to involve an oncologist in the follow-up of them, because they are more prone to other tumors like osteosarcoma or the primary neuroectodermal tumors, etc., etc. So this will conclude our lecture. I hope I made it easier rather than more difficult. If you have any questions, just feel free to ask, whether now or later on. Any questions at the moment?
Thank you very much, Doctor.
More than welcome. Inshallah, hopefully within this week, I will upload the recording to YouTube and send you the link for that, so that you can go back and check it if you need. Okay. Sorry for keeping you that late, and thank you for your attention. All the best, and if you need anything at any time, just don't hesitate to contact me. Okay.
Thank you.
Good night. Assalamu
Thank you.
alaikum. Wa salam.